heart and chest. I apologise for you not being able to see my face. My camera isn't playing ball, but I'll share my screen with you as soon as we start. So there's been a bit of a series, and there's been a few people doing community-acquired pneumonia, and I believe that Justine just did sepsis and pneumonia and the complications. So today we're just looking at an overview really of some of the complications that we might see in community-acquired pneumonia. And hopefully, if you've got questions, feel free to pop your hand up along the way. If that's the case, then you need to pop your screens on so I can see you on the cameras. If not, use your little wavy hand, and that's fine. And we'll go from there. And obviously, if there's anything that comes from today that you think you want a little bit more of, or you know, isn't a topic that is being covered and you want that, just please feed that back at the end as well to Claire, and then we can hopefully try and support you with any of the learning that you require. Okay, so I'm just going to share. Okay, so obviously this is just the series learning outcomes, and we did the diagnosis and management of community-acquired pneumonia last time, and today we're going to be looking at those complications. No daft questions. Respect each other, interact please with the session because it helps it go a little bit quicker, and obviously you get the most out of it at that point. I've mentioned the Teams facility, and most of all just kind of try and enjoy what's being said really. So just a quick recap. This is kind of fundamental really, the assessment of the community-acquired pneumonias, and it kind of guides what we think may become a complication with this patient, because we're looking really at the group at the bottom of that page, this group here. We're looking at the 3 to 5s really. Some of the 2s might dip into it, but a lot of the 3 to 5s will get some or more than one of these complications that we're going to discuss today. And obviously, if you're not in the hospital, you have the CRB 65, and again we're looking at this group here, the high mortality group, and possibly just dipping into the 2 as well, but the majority from the 3 and 4. Obviously you've got the pneumonia severity index for those that use it, and again we're looking at the inpatient group, or Vanessa, even the brief inpatient group. Yeah,
sorry to interrupt, we can't see nothing on screen at all.
Oh, hang on, not sure why, because I've shared my screen. Bear with me. Let me try that again. Can you see now?
It's just a...
Hello?
No.
It's blank. It's a blank screen. Oh, yeah.
Oh, no,
now
got it there. Yeah, you've got it now?
Yeah.
Yeah.
Fab. Okay, let's head back. Sorry about that, guys. Thanks for letting me know.
Don't worry.
Okay. So again, I was just looking there. So we've talked through this part here already. We don't need to do that again. But yeah, just looking at this group at the bottom here, the 3 to 5s, the ones that we're looking to admit, manage as severe, or even the 2s, which are likely to need admission as well. And then for those who are out in the community, looking at this group here with the CRB 65 of 3 and 4, or even just tipping into the 2s as well. The pneumonia severity index score, for those that use it, we're looking at 4 and 5, or even the tail end of the 3s. So from a complications perspective, obviously, initially it's just clinical failure. So those patients that just don't seem to be responding in the first instance. We're looking at those that develop sepsis, those that will develop C. diff, pleurisy, onto a pleural effusion, some of which may end up with an empyema, lung abscesses, those who have cardiovascular events as kind of a spin-off really for being systemically unwell. And there's a lot to be said at the moment about CAP not just being a disease process or an infective process, but actually being a systemic illness. And then incorrect initial diagnosis. So you may have those patients that we thought were a CAP, and actually when you look for it closer at it, they've maybe got something else going on that we didn't spot. And then those that don't resolve for whatever reason, either within the initial stages in clinical failure, or those that are 6 weeks down the line, have their repeat chest x-ray and they've actually still got infiltrates notable on their chest x-ray. So just a few stats really. 7.7% of pneumonia patients will develop C. diff. So it's actually quite a high number really of patients that we should be supporting with that and letting them know kind of what to expect and how to best manage themselves. Up to 2/3 of patients in hospital or that get hospitalised with it will develop a pleural effusion through community-acquired pneumonia. Now, I don't know how many people thought that would be, but I think that's quite a large chunk of patients really, and probably don't look out for it as often as I should. 1/3 of all C. diff infections in hospital are patients who have had pneumonia. So there's a big chunk of those, although it's only a small amount, 7.7 of the pneumonia patients that have C. diff, the total number of C. diff infections have pneumonia. And it's actually treatment of pneumonia in hospitals is perpetuating C. difficile cases throughout the world, not just in the UK. Empyema affects 1% of our hospitalised patients. In the severe CAPS is 25%, so it's a good chunk of people, 1 in 4 that you're seeing essentially might not be with us in the next few weeks. 1% of those deaths though are due to those in ambulatory patients, so it's quite a quick thing really. If somebody's up and mobile, you don't necessarily have to worry about them quite so much as those that are bedbound through the illness. Okay, so I know that we went through sepsis last week, so I'm just going to briefly touch on this. So basically commonly affects those with severe pneumonias. Main symptoms include high temp, leukocytosis. For those that don't know what that is, that's white cells, essentially high white cell count, tachypneic and tachycardia. So those that are suffering with high rest rate above 20 and tachycardia above 90, but worse so above the hundreds and 110. Treatment is as per your local policy for sepsis management. If you've got a suspicion for this, give oxygen. If you know that somebody has a sensitivity to oxygen and they do retain, then please document that in the notes. We have a nice situation here where we actually have community contact with patients that come in, so we will know already if somebody's at risk of type 2 respiratory failure, and we can tell them target SAT straight away so that they're not looking for the usual above 94% with patients, and obviously that can prevent further problems down the line. Getting the staff in the hospital to get urgent blood tests, microbiology samples, give IV broad spectrum antibiotics at first. Obviously, if they're not that unwell, and you're thinking, like they're just on the cusp of sepsis, they might start them with oral antibiotics first, but that'll be usually a discussion with the sepsis team. Give an IV bolus of fluids to restore tissue perfusion and check the lactate. So we'll do ABGs in here, and that will come up with that as well. And then obviously monitor urine output and fluid balance hourly to just make sure that they are actually passing urine. And for those that aren't sure what normal urine output is, you're looking for 1 ml per kilogram per hour. Okay, so we're looking at those patients that are shifting that. Obviously, this is kind of the thing that's been circulated more recently. Obviously, they used to have the old version of SIRS, and now they've switched it to, do they look ill? Are they triggering on their early warning score? And are there any signs of infection? Essentially, this could be sepsis. So that's what we need to be doing, the sepsis 6 that we just spoke about. Okay, and there it is again. So these are things that a lot of us can be doing. And obviously that can, if it's not treated and we miss it, it can result in multi-organ failure and shock. And that can commonly affect those with severe community-acquired pneumonia. If it's missed, it can often be fatal. So this is something that it's quite easy to spot when you use the new version of, do they look unwell? You know, it's a simple thing. Do they look unwell? Is there a sign of infection? You get those bloods back relatively early if the white cells are up and the CRP is up, you know, the leukocytes up. You can move forward with, yes, they're definitely unwell. If we recognise this early, then you're more likely to survive it, and with immediate intervention, we can support those patients. Obviously, we're looking for kind of fever, tachycardia. Is the rest rate up? Are they shaking? Are they struggling to keep themselves still because they're trembling? Are they hypertensive? Do they feel a bit nauseous? Are they vomiting? You know, as the ambulance crew come in and said, oh yeah, they've vomited on the way in, suffering with diarrhea for the last couple of days, and just generally feeling unwell. Are they confused at all? That's obviously a worrying sign, and we need to be acting pretty quick with those patients. If they're in hospital, fine, we can do the blood cultures. But if they're community-based, have they had blood cultures when they've been in hospital, if they've gone home, or have they had any done recently for any reason? And we can look back at those. So C. diff is another complication that we've talked about, and like I say, a big number of C. diff infections have pneumonia. Obviously, a slightly smaller amount of pneumonias develop C. diff, but it's purely because we are essentially giving them antibiotics that affect the microbiome in the gut. And then on top of that, if we give them antibiotics and a proton pump inhibitor, that is, them two together really increase the risk of somebody developing a C. diff infection. Okay, and if they have pneumonia and develop C. diff, there's a 1 in 4 chance that they won't be here in 30 days, which is massive. So we really need to try and avoid this. And obviously, if it starts to happen, that the stools are starting to get loose and things like that, then we need to really be looking at, do they still need these antibiotics? How long have they had them for? Can we get them off? Or can, you know, what else can we do to support this patient to improve and make sure they're fully hydrated? So pleurisy is a swelling of the outer line of the lung, or the line of the area of the chest where the lungs sit. It can develop just because the community-acquired pneumonia has not been managed very well. And often the patients will describe kind of sharp pain, worse when they're taking a deep breath, cough or sneezing. Pain can move around into the back or up into a shoulder. They can often get a temperature with it. They just have difficulty breathing, or more importantly, that reluctance to breathe. And because of that, they tend to breathe a bit quicker. So they might have a higher respiratory rate, and yet they don't look like they're struggling too much. They're just breathing more shallowly, so they're happily panting away. And as somebody that's previously had pleurisy, I can tell you it's extremely painful. So this is definitely something that the patient will report, that they're really in a lot of pain when they're trying to take a deep breath. Okay, often we'll look for adequate analgesia. This is the most important thing, because if you have pleurisy without a pneumonia, then this can stop other things happening if you get good analgesia on board, so somebody can take a deep breath. Otherwise, they're just a sitting duck for further problems. We can do chest X-ray, CT, or an ultrasound, and sometimes they'll do a little aspiration and just see if there's any issues, any pus growing or anything else going on inside. And then anti-inflammatories can help the linings of the lungs to actually reduce that inflammatory process, and then hopefully pass a bit smoother across each other and stop the pain. You need to also rule out cardiac cause of chest pain, just to make sure that it's not cardiac in nature. I know that in Liverpool Heart and Chest, we've got our own chest pain kind of pathway, and hopefully you have in your areas as well. And if you're not familiar with that, I would definitely suggest that you take a little look at your chest pain pathway and make sure you're familiar with it and understand how to use it, so that if you do get a patient with chest pain, you can appropriately follow that through. Sometimes when that pleural rub happens, it can create an increased fluids, and that can fill up the area between both pleura, and that can cause a pleural effusion. And then again, similar situation. People have difficulty when they're breathing. Often when you're listening to the chest, to the breath sounds within the chest, you'll be looking for obviously a lack of breath sounds where the pleural effusion is. So you'll have lost some breath sounds in an area of the lung, and also just at the very top of the pleural effusion, you will hear a band of bronchial breathing, and that is because you are essentially getting the edge of the lung on the sitting on top of that pleural effusion, and that then obviously gives you a slightly different sound. So that sometimes it's a nice way to differentiate what's going on, whether somebody's got a consolidation or whether they've actually got an effusion. So that's quite nice to listen to, but it's a very small band and you will miss it, you know, if you're not particularly looking for it. But if you actually auscultate up from the bottom, and you'll probably get to it and won't miss it, and just try and make sure that you do kind of stethoscope widths until you get to the top of it. It's nice to hear. Obviously this here is just a nice picture of a pleural effusion, and this is somebody upright. Okay, so if you're sat upright, a pleural effusion looks like this, and it's contained usually within one side. You can get bilateral pleural effusions, but in this case it's just a left-sided pleural effusion, and often at the edge of the pleural effusion you'll see a little tip up, little flick up on each side, and that is just like a water line essentially. You know, you can imagine when you're in the bath or when you've got a bowl, the edge of the bowl with the water in, the water tips up, and it's just because of hydrostatic pressure, it will actually lip up at the side. So that's a nice way to see if it's pleural effusion rather than a consolidation, because a consolidation doesn't have that same picture. So this affects kind of 1/3 to 2/3 of hospitalized patients. Often they'll do an aspiration, and they'll do a little needle aspiration, and they'll look to see if we're growing anything within that. Are we growing any organisms within it, or is there any pus identified, and what's the pH like of that fluid? And if it's less than 7.2, or there are some organisms, they'll do an intercostal drain and try and kind of essentially get that fluid out and help the lung itself to re-inflate into that space. Often they'll pop this on suction, and that will help it to re-inflate, and obviously they have a period of time then where they clamp it off and just make sure that that's not causing any problem and it's not re-deflating, and then at that point, if things look okay, they'll pop it out. When they pop it out, we keep an eye on that patient for the next couple of days, because there's a high risk that will reoccur, depending on what the cause is, and we just need to keep an eye and make sure that's not the case. And obviously we can do that through auscultating, through the percussion, and if it's starting to become dull again at that base, as long as it's not too severe, they'll often leave it without putting chest drains back in, because that can obviously cause more problems and potentially introduce more risk of infection. So that's what they'll do. So this is a slightly different image, and I just wanted to show you this because this is also a pleural effusion. Now it's a right-sided pleural effusion, and as you can see, it looks very different to the other one, and it's because the chest X-ray has been done in supine. So this could very easily be missed for something else. People might think that's a pneumonia in itself, without the pleural effusion. So you just need to be really mindful of the chest X-ray that you're looking at. What position was it done in? Just so that you've got a better idea really of what's going on. But it's just interesting to show you a slightly different view of a pleural effusion. Okay, sometimes when you have that fluid within the lung, it can get infected and essentially creates an empyema, so like pus, what we see in kind of whitehead spots, but unfortunately it's in between the two layers of the pleura. Obviously it's a very small complication, but does happen, and less than 1% of our patients do get it, but it's really important to recognize this and actually do something about it, because this can make somebody quite unwell if it's left alone. And it's very similar to the pleural effusion, they'll do a needle aspirate first and just see what's going on. They'll send it off for some cultures and sensitivity, because if we know what's in there, we can obviously give appropriate treatment. They'll then put an intercostal drain if that's what they feel is needed, and help that back with appropriate antibiotic therapy. And that can help somebody to reduce that empyema. But you can imagine it's like trying to breathe with a brick in the place of where you should be able to expand your lung. So for a patient, that's quite scary, and obviously can make them quite short of breath, with that inability to expand the lung fully. So this here is a chest x-ray of a right-sided empyema, and you can see it looks very different to the pleural effusion, because the fluid that's in there is more dense, it's a lot thicker, and although it is liquid, and you still have the slight lip up on the edge, both sides, it's a much stricter line. It's, there's a definite kind of edge to it, a border, and so it's much easier to spot the empyema than the pleural effusion. So just keep your eye out for that. If you get a really solid line like this, then they're probably going to have to go in and have a little look at what's going on. So lung abscesses, these can also develop, and from somebody who has pneumonia, and most likely those patients who have had a history of gum disease, bacteremia. Those that have a weakened immune system often develop lung abscesses. Those who have a history of alcohol excess. If your patient's male, it's more likely that they're going to develop a lung abscess. And if they're older, they're more likely as well to develop a lung abscess. Signs for this, very similar to all the rest of it. This is very difficult to differentiate, and I would definitely put a huge emphasis on your kind of clinical skills of assessing a patient's chest, from listening to the chest, from feeling for tactile fremitus, to listening to auscultation sounds, percussion notes. So it's really important that you get these skills down to a T. And if you're a bit unsure with those skills, spend some time with somebody that is quite skilled in that area, and you'll be able to listen to certain sounds. And the other thing that I suggest, if you've got a Littmann stethoscope, that you go onto the Littmann website and pop each Littmann stethoscope's got its own number on the outside of it, and that number you can put into the website, and you'll be able to listen to specific sounds, and they're usually very obvious when they do them as examples, so it's quite nice to hear the really obvious ones, and that can help you as well. But I think you can only have one per Littmann stethoscope. You get one kind of access code, and then you can use it. It's really good. Obviously, those who cough up pus can be a sign of an abscess that may have burst. Night sweats, not feeling hungry, unintentional weight loss, and fatigue. And obviously, if somebody comes to you with those symptoms, what would you be, you'd be thinking, wouldn't you? Oh God, is this something more sinister? Is there a malignancy potentially? But obviously you can still get those with a lung abscess, so we just need to be mindful of that. And this is a beautiful chest x-ray of quite a large lung abscess, but it's really clear to see. But you'll often get them like smaller ones, in different areas, and they're a bit harder to spot. But people can get, when they get atypical pneumonias, you can see them, and sometimes these develop where the body kind of encapsulates the pus away, but it's obviously quite worrying for a patient. Management of these, very similar to the previous complications. Chest x-ray, CT scan to just get the extent of it if required, needle aspiration, again cultures and sensitivity. They'll send off and give treatment with appropriate antibiotics dependent on the growth, and then obviously management of other symptoms. So if they're hot, paracetamol, reduce the temperature. If they're pain, give them appropriate pain management. So it's just the usual kind of symptom management signs, but obviously the lung abscess side of things will be looked specifically at respiratory specialists who will need to go in and do a needle biopsy. So respiratory failure. So when you have pneumonia, this is essentially what happens. and the alveoli get absolutely full of lots of cellular debris that ends up filling out that cell wall. You've obviously got a thickened alveolar. You've also got a thickened space due to neutrophil kind of migration into the area to try and treat the problem. It creates a thickening here, and obviously that in itself can reduce your ability to exchange gases, essentially. And obviously the wider that gap, the harder that is. And then also you've got other things going on within the cell itself, where you've got more surfactant, you've got your different cells within the actual alveoli dying off, sloughing within the bronchial epithelium. So the epithelium isn't working as efficiently as it normally would. And then overall you get a problem where you're essentially kind of drowning in your alveoli. So that accumulation of fluids, proteins and white cells within the actual alveolus itself can cause respiratory failure. Okay, and resultant hypoxemia. Okay. Pathogens linked to subacute and chronic community-acquired pneumonia. So sometimes you can be unfortunate and develop problems just because of the type of bacteria that you're actually growing, with less common bacteria. But these are some of the bacterium that if you have this bacteria growing, you're more likely to be more unwell with either an acute, a subacute, or a chronic community-acquired pneumonia. And they will need specific treatment for much longer periods of time than the usual kind of 2 weeks post cap, essentially. So just keep your eye out for these. And it's all Latin to me, which is what it is, but still it's remembering them is pretty much impossible. But it's just nice to be able to look back at them and see in future if you get somebody with typical pneumonia, what's going on. With those, obviously we'd be considering IV straight away if they're high risk, and obviously within an hour if we're querying sepsis, within 4 hours if they're not sepsis risk, and just make sure that you've got a sample so that we can help to narrow the spectrum of antibiotics further down the line to kind of appropriately treat these patients. If they're not resolving, so these patients kind of, you think, oh yeah, they've been on treatment for a couple of days, nothing, they've been on IVs, still the news is 6 or 7, they're not really improving much, they're feeling weak, and they've got purulent sputum. We need to just go back to the drawing board with them and start again, and go for a new physical examination. Are we potentially missing something? Is this patient not a CAP? Is something else going on and we've missed it? So I would repeat the bloods, repeat microbiology, and repeat the radiology, and just make sure that we're not missing something here and it's not something else going on, so that we can appropriately treat them moving forwards. If they've kind of been into hospital for more than 48 hours, or if they've been out of hospital less than 48 hours, think hospital-acquired pneumonia. So have they developed kind of signs related to hospital-acquired pneumonia? Now, we treat these essentially in a similar way, in the sense that we would, if they're not too unwell, we'd give them oral antibiotics. If they're potentially very unwell or then refusing hospital admission, maybe if you can get community IV teams involved, and get IV antibiotics on board. Obviously look, have they been in hospital? Are there any growth? Is there any cultures done? Do we have any sensitivities? Can we switch those to the appropriate antibiotics? Making sure that we are reviewing these IVs in the community within 48 hours. And now the community teams are really great at this anyway, and they will kind of come back to you if you're the prescribing clinician, and let you know that they've been on and the result seems to be resolving. Can we switch them to an oral, and go from there basically? But the first choice for HAP, nice guidelines, is coamoxiclav, and that's obviously if it's non-severe or signs, and they're not at high risk of resistance. So if they've obviously had previous growth that's been resistant to antibiotics, then we need to look at those sensitivities and see if we can switch them appropriately. Alternative antibiotics in non-severe symptoms or signs and not any higher risk of resistance for penicillin allergy, or if the Comox collab unsuitable, we can try doxycycline for 5 days, 200 milligrams first day and then 100 milligrams daily. Cefalexin, and just be mindful in those that potentially are penicillin allergic. 500 milligrams twice or 3 times a day, and can be increased to 1 gram or even 1.5 grams 3 or 4 times a day. So there's a lot of scope in cefalexin. Cotrimoxazole, again, it's a bit of a strange one, 960 milligrams twice a day for 5 days, and then review at that point, and levofloxacin. And I would they only suggest doing this if somebody's been in hospital and been on IV levofloxacin, and it's again with specialist advice, because that one's off label, so we just need to be mindful of that. Okay. So in summary, effectively assess our patients. It's really important that we know to avoid some of these complications, or to be mindful of these complications and get an early awareness of the complications and start to support them appropriately. We need to effectively assess our patients. And number one, bloods and radiology and everything else is great, but number one is listening to somebody's chest. Have a feel of someone's chest. What does it sound like? What does it feel like? How does the patient feel? Or do they feel like they're resolving? Do they feel like things are getting worse? Do they feel like they've been on antibiotics for 3 days and they're no better? No worse, no better, but just staying the same. Can you hear me?
Yeah.
Oh yeah, sorry. My computer looked like it had gone off. Sorry. Yeah, ensuring that we've got those 6-week 6-week follow-up for radiology where appropriate, and obviously those who have oral antibiotics and are treated well and seem to be resolving within 5 to 7 days often won't need a 6-week follow-up, but the majority of patients will need a 6-week follow-up radiology examination, and also potentially follow-up CRPs in the community. So our patients will go out with often with a CRP of in the 200s and need a follow-up in 7 days, just to make sure that that is returning to normal and resolving, so that we're not missing something. Safety net patients as to potential red flags, what to be concerned about, when to escalate if they're not being onboarded to the virtual ward, or they've not got any follow-up. Somebody potentially who's got no respiratory background condition might not routinely get followed up in the community, and if they've come in and actually the news wasn't that severe and they've been treated well on oral antibiotics, they're the ones specifically that we need to be making sure that we've safety netted appropriately, because obviously they're going to go home without that support, and it's really important that we do give them that support and that knowledge to pick up what's going on. Okay, any questions, guys?
No.
Okay. Are you happy for me to stop recording, Vanessa? Because I feel people are a little bit more confident to ask questions once the recording stops.
Yeah.
Perfect.
That's fine.
Fab. Okay, stop that now.